Welcome to Episode 5 of our DSM-5-TR series. I'm Psychotherapy Cynthia, and today we're covering anxiety disorders, which share excessive fear or anxiety and related behavioral disturbances, but differ in focus and triggers. This chapter includes separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, panic disorder, agoraphobia, generalized anxiety disorder, substance or medication-induced anxiety disorder. Anxiety disorder due to another medical condition, and other or unspecified anxiety disorders. In fieldwork, your primary task is to distinguish normal worries from pathological anxiety, and to differentiate between the various anxiety diagnoses. Separation anxiety disorder and selective mutism typically begin in childhood, with separation anxiety focused on excessive distress regarding separation from attachment figures, and selective mutism involving consistent failure to speak in certain social situations despite speaking in others. Rule-outs include language disorders, autism spectrum disorder, social anxiety disorder, and cultural or situational factors. Specific phobia involves marked fear or anxiety about a specific object or situation, leading to avoidance and immediate fear response, with fear disproportionate to the actual danger. Social anxiety disorder centers on fear of negative evaluation in social situations, while agoraphobia involves fear and avoidance of situations where escape might be difficult or help unavailable in the event of panic-like symptoms. Panic disorder is defined by recurrent, unexpected panic attacks and persistent concern or behavior change related to the attacks, whereas panic attacks can also occur as specifiers in other disorders. Rule-outs include medical conditions like cardiac arrhythmias, substance-induced anxiety, and other anxiety disorders where panic is exclusively cued by specific situations. Generalized anxiety disorder involves excessive anxiety and worry about various events or activities occurring more days than not for at least 6 months, accompanied by symptoms such as restlessness, fatigue, and sleep disturbance. Rule-outs include worry that is proportionate to life circumstances. Depressive disorders and anxiety due to substance use or medical conditions. Substance or medication-induced anxiety disorder and anxiety disorder due to another medical condition are diagnosed when there is evidence that anxiety is a direct physiological consequence of substances or medical issues. Other specified and unspecified anxiety disorders are used when the symptom picture is predominantly anxious but doesn't fit neatly into one diagnosis or information is insufficient. When you meet a client with significant anxiety, what 2 or 3 targeted questions help you quickly narrow down which specific anxiety diagnosis to consider first? Obsessive-Compulsive and related disorders. Welcome to Part 6 of our DSM-5-TR series. I'm Psychotherapy Cynthia, and we're now moving into obsessive-compulsive and related disorders, a chapter organized by the presence of obsessions, compulsions, preoccupations, or repetitive behaviors. This chapter includes obsessive-compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, excoriation disorder, substance or medication-induced obsessive-compulsive and related disorder, the version due to another medical condition, and other or unspecified obsessive-compulsive and related disorders. For clinicians in fieldwork, a key skill is distinguishing these conditions from anxiety and psychotic disorders that may look similar on the surface. Obsessive-compulsive disorder requires obsessions, compulsions, or both, which are time-consuming or cause significant distress or impairment. Rule-outs include obsessive-compulsive personality disorder, generalized anxiety disorder, eating disorders, and psychotic disorders where beliefs are fully delusional rather than ego-dystonic. Body dysmorphic disorder features preoccupation with perceived defects or flaws in physical appearance that are not observable or appear slight to others. Often accompanied by repetitive behaviors like mirror checking. Differentiate this from normal dissatisfaction with appearance, eating disorders centered on weight and body shape, and psychotic disorders where appearance concerns are firmly delusional and not recognized as possibly excessive. Hoarding disorder involves persistent difficulty discarding possessions regardless of their actual value, leading to accumulation that congests living areas and significantly impairs functioning or safety. Rule-outs include hoarding behavior that is better explained by OCD, depression, psychotic disorders, or neurocognitive disorders, which have different clinical pictures and treatment implications. Trichotillomania and excoriation disorder are characterized by recurrent hair pulling or skin picking, with repeated attempts to decrease or stop, leading to noticeable damage. Key rule-outs include dermatologic conditions, self-harm behaviors related to emotion regulation, and stereotypic movements in neurodevelopmental disorders. Substance or medication-induced obsessive-compulsive and related disorder, and the medically induced version, apply when repetitive thoughts or behaviors arise due to substances or medical illnesses. Other specified and unspecified categories again capture atypical or incomplete presentations where obsessive or compulsive phenomena are central. When you conceptualize a client with intrusive thoughts and rituals, what specific features help you decide whether you're looking at OCD versus a primary anxiety or psychotic disorder?